My name is Pete Lucas, and tonight's webinar is going to be hosted by University Gastroenterology. For those of you that are not familiar, UGI is based in Providence, Rhode Island, with locations throughout the state. University GI, in partnership with University Endoscopy Group, also has 4 ambulatory surgery centers conveniently located throughout the state, where they perform the majority of their procedures. The physicians at UGI are also affiliated with all major hospitals in the region. UGI consists of 25 physicians and 8 nurse practitioners, making it the largest and most comprehensive GI group in southeastern New England. This evening, I'm fortunate enough to be joined by 4 physicians, each with their own area of expertise. Dr. Elizabeth Decker is a Rhode Island native, board certified in gastroenterology and internal medicine. Dr. Jeff Nadelson, trained in gastroenterology and hepatology. Dr. Robert Najarian, a pathologist who has some very interesting observations on COVID-19. And Dr. Ravi Nadimpalli, a gastroenterologist and part of the Liver Center at University Gastroenterology. Tonight, we'll get to know these GI experts, discuss the current state of gastroenterology during COVID-19, and then at the end, we'll make sure to have time to answer your questions. So I'll bring this in a friendlier format so we can see each other. Dr. Decker, we'll start with you. As a native Rhode Islander myself, we always like to mention other native Rhode Islanders, and you are one. You traveled out, came back to Rhode Island to start your practice. Talk about your practice, what you do, and why you came back to Rhode Island.
Yeah, so I'm a classic Rhode Islander. I tried to leave a couple of times. I always came back. I really like the area. I have a lot of friends and family here, so that's really been important to kind of be that part in the community. Where I share ties and have a lot of close relationships. I'm now for my year practicing at University GI, and I'm practicing in general GI, seeing a variety of things, including IBD and some liver disease as well. And it's just been really great.
Great, and raising a young family as well. Dr. Jeff Nadelson, not too far away, right? Massachusetts native. Talk about you joining UGI and your specialty in IBD. And for those that don't know, what is IBD and what sort of illnesses does that cover?
IBD typically includes Crohn's disease and ulcerative colitis. Ulcerative colitis is typically when you have inflammation of the colon alone, whereas Crohn's disease, you have inflammation of the large intestine and the small intestine as well. This can range in severities where it can be very, very mild, where you take medications such as mesalamine, where it can be on this more severe side where you take a lot of the medication that you see on TV, whether it's the biologic therapy, such as Remicade, Entyvio, Stelara, all of these new and sort of fascinating medications that are becoming more and more popular as we go on now.
Great. Dr. Najarian, you're a pathologist. UGI brought you on a few years ago and undertook a big project to begin a pathology lab. Why is that so important to a practice like this?
Yes, I started, and my group started, partnered with UGI beginning 2 years ago. And all of us who work at the pathology center of UGI have expertise in gastrointestinal pathology. So we've received not only training in surgical pathology to look at all microscopically on a slide, but the bulk of us have received specialized training in gastrointestinal, liver, and pancreatic diseases. So we understand those diseases, identify them readily, and understand all of the subtleties which can be seen under the microscope that different patients present with, that may have very important implications for the treatment and outcomes of patients.
And while many patients will never see that lab, it's very important, and it's located out there in Portsmouth, and that's where Dr. Nadimpalli is as well. I think a lot of folks think of GI issues, they think of stomach issues, but a very important part of what you do deals with the liver. Talk about that.
Absolutely, Pete. You're right. The stomach and the gut get a lot of the attention when it comes to gastroenterology, but we also do take care of the liver. It's one of the digestive organs, but it's a powerhouse, and there's lots of things that can happen to affect the liver in the course of one's life. And so we specialize in that as well. A lot of people, when they think of liver disease, think of alcohol, but there are a myriad other causes. I have a particular interest in hepatitis C and fatty liver disease, which is becoming a bit of an epidemic in terms of the number of patients that are developing fatty liver disease and trying to manage it. Just as alcohol or hepatitis C can lead to cirrhosis, so can fatty liver disease. So there's a huge impact on patients, and it's an area that I'm happy to be able to focus on a little bit.
Great. And the reason why we're all here tonight is to talk about the current conditions during COVID-19 as they relate to your practices. And fortunately, here in Rhode Island, things have moved forward. Procedures have picked back up this week. But you all are at different centers. A great thing about UGI is you're spread out throughout the state. So we'll get kind of some input from each of you on how things have gone forward this week. And Dr. Decker, we'll start with you. You practice in East Greenwich. You've had procedures this week. How have things changed?
So obviously we've been restricting a lot of volume, trying to keep patients as safe as possible, social distancing in place, and really limiting the flow of traffic in patients. So we've done a lot of transition to telemedicine, which has been very helpful in taking care of patients who are having more mild symptoms, or even patients that are having symptoms increasing in severity before it comes to a point where it becomes an emergency and needing to subject them to the hospital or in the emergency room where there's a lot of patients there and a lot of traffic and a lot of extra exposure. So that's been very well received by our patients. They've really liked the access and the ability to kind of talk with us from the comfort of their home or from their car on their lunch break or coffee break, because a lot of people are still working really hard and using a lot of their PTO and sick time exhausted, can't get time out of work to come see us. So it's even filled that niche for those people that are still kind of covering the heavy loads in terms of the workforce. So our office flow has started to just pick back up. We're still maintaining social distances. We have a total of 6 rooms, and currently we're not utilizing all of them so that we can clean the rooms in a very aggressive manner in between patients. We have a one-way flow through our office so that patients are not getting exposed to the new patients coming in as they're leaving, and trying to make sure that the waiting rooms and other public spaces are as minimally occupied as possible at one time. And then we have an attached endoscopy suite, an ambulatory surgery center that at max capacity runs about 5 rooms, and we can do anywhere from 14 to 15 cases a day when our volume's normal. And at one point that cut really far back to about 1 room a day, where we were really taking care of patients who were just having urgent or emergent type symptoms at the hospital. So it's been exciting that we've been able to start to open that back up. And currently we're utilizing 3 of our 5 rooms, and that gives us the ability to rotate rooms in between patients so that while one room is being cleaned, we can utilize a second room to try to keep patients flowing through, but still providing a safe environment and keeping people away from each other as best as we can.
Great. And Dr. Nadelson, you said you were surprised at the return of patients. And I would assume if you do get a positive Cologuard test and you're put on hold for a few months, you'd be eager to get back. Talk about what it's been like for you at West River, one of the 2 Providence locations.
Yeah, when all of this sort of COVID started and we sort of came to a fast halt, and we were like Dr. Decker was saying, we were only doing emergent or urgent procedures. I really thought that sort of once the governor started resuming elective procedures, I really thought the upswing would be relatively slow. This week, I've been surprised. I have been surprised at sort of the patient response. And I think that's a credit to the governor. I think that's a credit to the Department of Health in Rhode Island. That's really kept the knowledge going about and keeping people safe. And I think people are getting that. And I think people are eager to get these procedures done that they've been waiting to have. I think Dr. Decker brought up really good points about sort of what each center is sort of experiencing in terms of trying to keep people safe. I know from, at least at our particular center, and I think it applies to the other centers too, we're no longer allowing family and visitors into the endoscopy center. The patients are coming in alone, wearing a mask, obviously keeping the social distancing intact. At our endoscopy center in Providence, we have the nice thing that there is physical barriers between each of the beds and the recovery beds and pre-op, which allows for, easy for social distancing. And so I think that has really helped, and I'm really interested to see how this next few weeks goes as we continue to ramp up our endoscopic services.
Dr. Nadimpalli, over the bridge at Portsmouth, those of us here in Rhode Island know that if people don't like to cross bridges, it's a convenient aspect of UGI having that location. For those that aren't from the area, Portsmouth is on the island of Middletown and Newport. It's a great place, especially in the summertime. Have things been a little bit different, slower out there, or are you seeing the same sort of thing?
Yeah, we are out here on the island. Not being a Rhode Island native, it kind of surprised me how much the bridges have kind of contained things, and how much people have been happy to have us on the island so they don't have to cross that bridge. I think our center has had a very similar experience to the other two centers, Dr. Dr. and Dr. Nadelson were talking about. Certainly when the epidemic hit, we put a halt to anything that was not essential, non-emergent, but we still stayed open to try to accommodate those patients, although on a vastly reduced basis. These, as the stay-at-home order has been lifted, and as we start to see more of these services coming online, I've also seen what Dr. Nadelson has seen, an uptick in patients rather quickly. I anticipated a relatively slow rollout, but there have been patients who've been waiting for a long time, and it's hard to realize how long we've been at this, given that we're all kind of getting through this day to day. But it's been a while. It's been a while. And so patients who may have already been waiting a few months to have their procedure and then had to wait an extra couple of months while we try to flatten the curve are, I think, eager to get their procedure done with and get taken care of. I think it's a testament to how much they trust us. It's also a responsibility for us to live up to that trust. And I think we're doing everything in our power to do that. At our center, we're a one endoscopy suite center, so there's only one room. That allows us to really tightly control the flow of patients in and out. There's only one physician working at any given time. And so what we've done is we've really built in a big cushion into the turnover for each patient. So there's not a lot of traffic in the waiting area. We're also implementing the restriction on patients' rides, trying to leave them out in their car so we can bring the patients to them, and just limit the number of people that are getting exposed to one another. And also using personal protective equipment to safeguard ourselves and our patients.
You don't need to cross a bridge to get to the lab. It's in fact right down the hallway. I've been there. And you talk about tight quarters. Dr. Najarian, give folks an idea of what the lab is like and what sort of things you see there and what you're able to do in a confined space.
So it is a very busy space, and when we're operating at full strength, it can be a very crowded space, not just with the equipment that we have for processing all of those biopsy samples that are collected at colonoscopies or endoscopy procedures, or from the equipment that do a lot of the ancillary testing that allow us as pathologists to figure out whether there's infectious organisms or other things going on in a particular biopsy sample. But there's also people. There's a lot of people, talented technical staff that operate this lab from 5 a.m. to 5 p.m. 5 days a week. So it certainly is challenging, like it is in a lot of office environments, to strategize and find ways to effectively physically distance ourselves as workers from our partners who we might be working with on a daily basis. And of course, what Liz and Jeff and Ravi have already alluded to, the fact that volumes have dropped during the height of the pandemic has certainly helped with the number of people that are actually required to be in the lab at one time. Now that folks are coming back for screening, essential screening procedures that they have put off out of necessity during the height of the pandemic, we have been spending that quiet time during the height of the pandemic, planning for effective physical distancing strategy, and going forward, how we'll handle an ever-increasing volume of specimens, patients' biopsy samples that we'll see.
Got to ask you, as an expert pathologist, your thoughts on COVID-19 and this virus, and how tricky it's been to pinpoint, figure out, treat, and come up with a vaccine for.
Yeah, so interesting times for sure. Uncertain and scary times, certainly at the beginning of this, because after all, like all of us, like the public has been, when we started out in this process, all we really understood about the virus was what we knew about the family of viruses, coronaviruses that COVID-19 was a part of, and the news that we were hearing from other places that were confronting this disease first. So places in Asia, certainly, and then subsequently in Europe. So it's certainly been, there's been a lot of unknowns, which myself and the field of pathology tends to love, and a lot of the people that go into pathology love the unknown and being able to provide guidance and answers, ultimately, from a lot of the unknown. And I think that we certainly, as oftentimes we are, the first patients to actually confirm that a patient is positive with the virus or not, we've certainly learned a lot about testing strategies and which are the most accurate, which will provide you fast results, but not necessarily the most accurate results. So helping to guide the public and the overall medicine overall toward the most effective strategies for testing and diagnosis of patients has certainly been challenging, but also an exciting duty, a part of what I do as a pathologist and an expert in laboratory medicine as well.
Very interesting. And it brings up a point early on where you talk about the cases being down. It doesn't mean that the cases have been on hold or gone away. And I'll ask all of you gastroenterologists about this. What is your advice now to those folks that have been on hold, that are maybe have been afraid to bring things up? We hear a lot of the news about stroke and heart issues, but certainly GI issues as well. So Dr. Decker, I'll start with you on that.
Yeah, I mean, we're certainly seeing some of the effects of people who are a little afraid. It seems like sometimes people are masking their symptoms more, and unfortunately it's starting to snowball in some effects. And I would just encourage you to stay in close contact with your providers. And again, I think not just as gastroenterologists, I think we all share this goal of trying to keep people home and treated as an outpatient as best as we can. Calling your doctor isn't always going to end up in getting sent to the emergency room. Everyone's doing the best we can to try to keep people as safe as possible. And we just want to know about what the symptoms are and how we can start to manage them before they get too severe and then result, unfortunately, sometimes in a hospitalization, putting them more at risk. We take this very seriously, the responsibility, as Dr. Nadimpalli was alluding to, of keeping everyone as safe and according to the guidelines as we can. And And, we just all kind of try to work together here to keep everyone safe and just get the routine care back on ball, because, as Dr. Nadelson also alluded to, people have been waiting for a long time to get these cases done. And so the longer we wait, the more of a chance that things kind of develop.
Dr. Nadelson, your thoughts on that, and what sort of signs should folks be on the lookout for that probably should be brought up and reached out for medical attention?
Sure. I mean, the red flags, particularly if we're talking about colonoscopy and people have been waiting, constipation, rectal bleeding, significant weight loss. These are all big red flags that we look out for when we're discussing and seeing our patients in the office. But I think when it comes back to people's concerns, I think it's really important that, the doctors and the patients really keep this this is a good time. And I feel like this has been a time for us when we've been on telemedicine to really create this sort of different relationship with our patients that we weren't really having before. And I think that the patients, because we're not seeing each other, we really have to have this trust of over the phone or over the telemedicine in the computer. I think if patients have a lot of concerns, they should, really feel comfortable in picking up the phone and asking any questions that they may have, whether it's going through our secretaries and our staff at the office, or, I'm sure all of us would be more than welcome to pick up the phone and answer any questions people may have. I think the doctors share some of the same fears as the patients do. I think we all have families, and we all have young children, particularly on this panel, where we all have our concerns and we all have our fears, and we're not much different than the patients. And I think that that's important for the patients to know that, we're trying to keep their best interest at heart, and we share a lot of the same concerns as they do, and we're there to help them.
Dr. Nadimpalli, your thoughts on this and some of the, I guess, the benefits of this situation, maybe having more time to talk to your patients, and it's never maybe been easier to reach out to a provider.
Yeah, I certainly would echo what Dr. Decker and Dr. Nadelson have said. I think part of the reason that people may ignore their symptoms and leave them alone is they're worried that we're going to send them to the emergency room, to the hospital. They're nervous about their symptoms, and they are afraid that we're going to put them at risk by doing that. But we're all well aware, and as physicians in general, we try not to take risks that aren't necessary. And we're very mindful of knowing that the exposure to other people and other patients is going to be a risk in the immediate future. So I know personally I've been very willing to work with my patients to try to craft an outpatient plan, a plan that limits their exposure. And so I urge people not to be afraid to reach out. We have been given the gift of telemedicine. At least for a short time, we've been allowed to use it as a tool to reach out to our patients and have insurance allow patients to do that. There's always been the joke about doctors don't make house calls, but this is a virtual house call that we're making so patients don't have to leave their homes. It's actually been kind of an eye-opening experience to meet patients in their homes and sort of get to see another side of them. But it's also been, I think, a really easy thing once you're over the daunting aspect of it. I urge patients not to be afraid of the technological part of it. And I know one of the things that is a barrier with this telemedicine is that some of our older patients may feel a little nervous about this, or patients hear the word telemedicine, it seems like a foreign thing. But we do have a lot of great staff that we work with. I'm lucky to work with a lot of good people, as are Dr. Decker and Dr. Nadelson. And so we have patient people on the phones that can help guide patients through telemedicine. And it really can be as easy as clicking a link on your phone when your appointment is up. And then you just talk kind of like what we're doing now. And it's been a really helpful tool in providing care for patients and limiting their risk.
Great. And I had a question come in about seeing the commercials for the take-home testing kits. And would it be safer to go with one of these rather than go with a scheduled colonoscopy, or if they're on the fence? And we'll get Dr. Najarian, your take, and then the other providers on on this? You see the tests that come in. What do the numbers say, and what would your advice be?
So if we're talking about the commercially available screening tests for stool tests for for polyps and cancer in the colon, I think that those tests serve an important purpose in that they can direct a lot of people who might be or might have been afraid to go ahead and get a procedure, direct them to a provider that they need to see. One of the fine gastroenterologists at UGI who can find out if their test is abnormal by colonoscopy, what's going on with them. Because after all, they're certainly, and I've heard it in my own family and, talking with folks who are of the age that need colonoscopies, there might be that anxiety about it. And, they might say, unless I have a problem, unless I feel like I have a problem, I'm not going to go for a colonoscopy. So I think that these tests offer an advantage of directing patients who would never have gotten a colonoscopy in the first place. It helps them to figure out, gee, there might be something going on. And even if it, certainly we hope that if it's an abnormal or positive test, that it is a polyp that is caught before an actual cancer develops within it, because that's the best time to catch these. And that's really ultimately what colonoscopy is best at, and why colonoscopy has really saved lives, cancer, death lives, people from dying of colon cancer, because the tests help direct patients to providers that will ultimately do the proper procedure, a colonoscopy, to help me as a pathologist get to the right diagnosis, and in order to stop bad things like cancer from occurring.
There's a lot more to that too, Dr. Decker, that folks don't probably understand when they go that route. Talk about some of the things that might pop up and surprise folks.
Well, I mean, one of the problems, with colon cancer and advanced colon polyps that have the potential to develop into cancer is they're usually asymptomatic. And that's why, we do these routine screenings. And so while everything, I agree, does have a little niche to it, we do still recognize colonoscopy as the gold standard because it has the advantage of not just being diagnostic, but also being therapeutic, where a majority of these polyps we're able to remove endoscopically the same day of the test, to kind of prevent that anxiety of what is this? Is it a false positive? Is it something real? Is it something I need to worry about? Especially now when we're having, restrictions as to booking. Some people are having to wait months to have to get their colonoscopy after a positive non-invasive test. And certainly people that are of higher risk need to be a little more aware of the caveats of these non-invasive testing. And there is still a significant false negative rate, so that can be up to 8% in some cases, meaning 8% of people that have a cancer may have a negative non-invasive test. And in a situation where you're not going to have symptoms necessarily, if you're someone who has a family history of colon cancer, a family history of colon polyps, or you yourself have had colon polyps removed, you really want to make sure that you're getting the best test available to you to further, provide care and prevention.
Dr. Nadelson, if you have a take-home test, it's covered by insurance, you covered once and you test positive, are you covered for that procedure once you go in and have to get a colonoscopy?
I'm sorry, can you repeat that?
Sure. If you do that take-home test, that may be covered by insurance. Are you then covered with a follow-up procedure if you do test positive?
Yeah, so I think that's really important for people to know. I have been in the, the experience where patients have been offered the Cologuard, but they really didn't know what was going to happen if it came up positive. They were just hoping and praying that it was going to come up negative, and lo And behold, it came up positive, and what do you know? They're getting a colonoscopy. And that wasn't really what they thought was going to be happening. So I think, once again, it's all about sort of asking the right questions, being knowledgeable. And I think, like Dr. Najarian was sort of mentioning, I think at the end of the day, this is all about expanding the patients that are being screened. And I think he brings up a really good point that a lot of these other stool tests enable patients to really have another opportunity in order to get screened. And so what ends up happening is we end up with positive tests that maybe we would not have gotten before. And we end up capturing those patients that may have been lost to follow up, or ended up, with colon cancer down the road. And this is a really good opportunity for take care of it before it gets to that stage.
And Dr. Nadimpalli, what's the percentage of patients overall that do have polyps? And as a follow-up, what should someone do had they scheduled the colonoscopy, been put on hold? Should they call the office? So kind of a two-part question for you.
Sure. I'll get to that. I just wanted to touch base and give my little 2 cents about non-invasive testing really quickly as well. I think I can speak for all of us in saying that every gastroenterologist is hopeful for a non-invasive test at some point, something that would expand the willingness of patients to get screened. Colon cancer and colon polyps are very, very common, unfortunately. But unlike other cancers, the average colon cancer grows very slowly, and it takes a long time to develop. So we actually have an opportunity to take care of patients who we identify early, or who identify with having polyps before things even become cancer. So we have an opportunity with colon cancer, and over the years, we've actually made a big dent in colon cancer rate. But we also know that there's a big unknown. There's a bunch of patients who don't get screened, patients who are eligible for screening but don't pursue it. And having a non-invasive test does offer an opportunity to capture those patients. The problem is the technology is not quite there yet. And unfortunately, like many things in medicine, it's kind of complicated. And we talk about false negative and false positive rates. Sometimes you get a test that misses patients that have a problem, and in other cases you get a positive test and a patient is up at night wondering worried that they have colon cancer, having to wait now in the midst of this pandemic for perhaps months, wondering if they have a problem before they are able to get a colonoscopy. The colonoscopy is not appropriate for everybody. Non-invasive testing is not appropriate for everybody, but trying to figure out what is the right test for the right person is a key part of the conversation you should be having with your primary care physician. If somebody is elderly and frail and has had a bunch of cardiac issues, they're not a great candidate for doing a colonoscopy. But similarly, if somebody is 50 and has a strong family history of colon cancer, and in fact 5 years ago had polyps on a colonoscopy, well, that's not the appropriate patient for a non-invasive test as well. And then there's all the financial implications that come into it, because unfortunately we all know that insurance companies have issues where people may not be aware that one screening test will be covered, but then if that test is positive, the next part of it, if you have a positive stool test for colon cancer, and then you end up getting a colonoscopy, that colonoscopy is not covered as a screening test, and so people end up being blindsided by the cost of that. As you alluded to, colon polyps are very, very common. I think national average right now is about 25% of women and 35% of men have precancerous polyps. But I know over the years of practicing, we keep a close eye on our rates. And I find that the numbers for myself and my colleagues have often been much higher than that. Some of the numbers are before we had high definition scopes, and so we may have missed polyps, but I would argue that the rates are closer to 45% that will find precancerous polyps for patients at the age of 50 with no symptoms. And so colonoscopy is our chance to find those polyps and remove them and prevent a problem down the road. Thankfully, it's a test where if you don't have a polyp, we can wait a good long while between repeating them. For some of the non-invasive tests, you have to do much more frequently for them to be effective.
So you mentioned.
I'm sorry if I missed the second part of your question, Pete.
No, that was it. I'm sorry. The second part was if someone has one scheduled, had one scheduled, postponed, what's the protocol right now?
Thank you. So at this point, we are opening up to patients, but on a kind of slower basis. So we encourage patients who've been putting off their colonoscopy to call and schedule. But be patient with us if we are putting it out for a little bit, only because we're trying to build in a big cushion between patients, so that we have that time to make sure that everything is safe for each patient and taking that time to turn over the room appropriately.
You brought up a good point about the percentage you're seeing in positives going up. Dr. Najarian, a couple of years ago, the American Cancer Society lowered their guidelines, their age guidelines to 45. What's the reason for that?
So, and the reasons, a lot of that is based on numbers and population-based study of who actually gets colon cancer and who is dying from it. And of course, you know, the screening guidelines, the original ones, or the ones that have been in place for a long time, have always said age 50, assuming no other risks like inflammatory bowel disease or family history or personal history of polyps. But unfortunately, what I've seen in practice is that all too often patients in their 30s and 40s are presenting with colon cancers. And while colon cancer rates have gone down, largely due to colonoscopy, colonoscopic screening in patients 50 and over and younger patients with risk factors, colon cancer diagnoses and deaths have actually increased in patients who are younger than age 50. So this is in large part why a lot of the national organizations, including the American Cancer Society, as you mentioned, recommend your first colonoscopy be at age 45, assuming no other risk factors for the development of colon cancer. And in my practice and experience diagnosing all too many patients with colon cancer at too young an age, I'd say that these are very sound recommendations for sure.
And every March is Colon Cancer Awareness Month. We bring these topics up, they come to the forefront, but what are some of these reasons? It seems like there hasn't been anything concrete, but Dr. Decker, what are people pointing to? Lifestyle habits, things like that. We always say people are living longer and being healthier, but this statistic is kind of going in the opposite direction.
I mean, some of it has been hypothesized to be linked to some of our dietary choices, especially in the Western world. Obesity certainly puts you at risk health-wise for a myriad of things, and it's been hypothesized to include colon cancer as well. And some of the high nitrate foods have preservatives in them. The deli meats and higher red meat diets have been thought to be kind of contributing to some of that as well. And I think it also comes along with some of the comorbidities. We're diagnosing inflammatory bowel disease, ulcerative colitis, and Crohn's so much more frequently now as well, whereas these patients may have gone undiagnosed and ultimately had a lot of symptoms or even some early morbidity or mortality from those diseases before colon cancer was even diagnosed in them. So I think a lot of it comes down to we're looking for it more aggressively. And I think there's also possibly some lifestyle. Cigarette smoking certainly can increase your risk as well that we've adopted that are certainly playing a role as well.
I don't want to jump topics too much, but yesterday was National Hepatitis Testing Day. And I think it's important to point out we're in a state that has an older generation. Hepatitis probably doesn't get as much news, especially with what's going on, as it should. But Dr. Nadelson, Dr. Nadimpalli, both experts in liver. Dr. Nadelson, why is it important to get tested for hepatitis, and any of the versions of hepatitis?
It's incredibly important because particularly viral hepatitis, more often hepatitis B and C are most patients are asymptomatic. And so most patients who may have illegal drug use, or IV drug use, or have received blood transfusions long ago. They may not even know they have the disease, and so it's incredibly important that we screen them. And I think the guidelines have actually changed when it comes to hepatitis C screening relatively recently, where the screening recommendations for hepatitis C was for for people who are at risk, and for the baby boomers who are born between 1945 and 65. Well, the new guidelines are stating that at least everybody should be tested for hepatitis C at least once in their life, which is a little bit different than previously recommended. If people are diagnosed with hepatitis C, the treatments now are terrific. Whether we have a lot of great options, whether it's Epclusa or Mavyret. We have a really, people can be cured up to 95% of patients if they take the medicine properly, and that's an incredible advancement than we had previously. And if we can cure hepatitis, then that prevents cirrhosis, decreases liver mortality, and also decreases overall mortality as well. And so these kinds of months, whether it's breast cancer month, colon cancer month, hepatitis month, all bring sort of a increased awareness to these kinds of things that keep our mind and eye on the ball, and keep us continuing to talk about it. And that's really what matters.
Dr. Nadimpalli, you spent a lot of time studying and being trained on liver disease. What are your thoughts on that? And for those that don't know and aren't familiar with hepatitis, what is it?
Well, it's a virus, and I think we certainly all have viruses on the mind at the moment. And obviously, our efforts are to get rid of coronavirus, and that's I think the end to that can't come soon enough. But once the dust finally settles on that, we still have this battle that we've been fighting for decades now of treating chronic viral hepatitis. Hepatitis is a category of viruses that affect the liver. There are some that are more benign, like hepatitis A, where you can catch it from food. But hepatitis B and hepatitis C are particularly prevalent and can lead to chronic liver disease. They can be fairly easily transmissible. Hepatitis B through blood contact, fluid contact, sexually transmitted, and hepatitis C primarily blood-to-blood contact. As Dr. Nadelson was saying, we're seeing the guidelines change a little bit on who needs to be screened for these things. And part of the reason is because treatment has evolved so much over the years. When I first started my career, we were still treating hepatitis C with injectables and pills that would kind of ravage the body. It was miserable to watch people go through these treatments for a year, feel miserable, and the rates of cure were decent but not great. There was still a decent chance that you would finish a year of feeling miserable and giving yourself a shot every week and still be sick, still have the virus. These viruses can lead to liver cancer, they can lead to cirrhosis, and they can lead to all kinds of other complications. But particularly with hepatitis C these days, we actually have much easier options with which to cure people. And the cure rates now are greater than 95% with a lot of these medications, which people take once a day. And I tell people, back when I was using the older medications, I'd be on the phone with patients once a week, telling them, look, you can do this, and giving them a pep talk and trying to play cheerleader. And now all I hear is crickets. People tolerate these medications so well that I never get called about them. And I'm forced to reach out to patients to remind them, hey, it's time for you to get your blood work. It's time for us to check on how you're doing. And they're like, Doc, I'm fine. Leave me alone. I've got work to do. So it's really been a revolution. And I think the change in screening guidelines echoes that. When we were first trying to treat hepatitis C, we would say, all right, well, if you ever had a transfusion before 1990, or if you ever have needle drugs or a back alley tattoo, let's test you. But let's not test anybody else. And that led to a little bit of a stigma with hepatitis C, where people would think, okay, well, it's only IV drug abusers who have a risk for hepatitis C. Turns out that it was probably more easily transmitted than that. And once we started having easier options for treating patients, then we expanded that to include boomers, basically anybody born between 1945 and 1965. Being in a state where we have a lot of people who work on fishing boats, there are a lot of cuts and bruises and accidents on fishing boats, and blood-to-blood contact is pretty common. So I have lots of patients who are longtime fishermen who may never have engaged in risky behaviors, but just being on a boat like that has put them at risk, and they are positive for hepatitis C. As time, so for a while there, we were pushing the whole baby boomers and trying to eliminate the stigma that it's only IV drug abusers who are at risk. Now it's gotten to the point where not only do we have this medication that's very, very effective, very, very tolerable, but now it's actually, because there's so much competition, it's relatively more affordable than it was. Still not cheap, but it's cheaper than when it first came out. Now the push has been, hey, let's try to eradicate the virus at the source and try to kind of eliminate patients who may not have been suspected to have it, but if we can get all these patients who have it and could be transmitting it to other people, if we can get rid of the virus for them, then we can actually do a lot of good for the population as a whole. So this is where the guideline to screen everybody over the age of 18 at least once, it comes from. In addition, they're saying we should screen patients who are at risk, so patients who do use IV drugs, we should screen them periodically. But patients over the age of 18 who don't have risk factors, we still should screen them at least once in their lifetime, because we do have a really decent chance of getting rid of this virus.
And you mentioned early on the virus on everyone's mind, obviously, is COVID-19, and different treatment than what we can expect with hepatitis. But Dr. Najarian, you don't have a crystal ball, but what can we expect, as providers and as patients over the next 6 months and 12 months, and what can we hopefully look forward to in a best case scenario?
So certainly, we've heard just recently, one of the many companies working on a vaccine about promising early studies, and that those few patients who were administered the vaccine actually mounted an effective level of antibodies in their blood, which is, of course, a very positive development. But of course, it's also a very the earliest phase, in fact, of study of vaccines. So, and there are a lot of other companies also who are working on the vaccine for COVID-19. So ultimately, that is going to be, I think, the most revolutionary and definitive therapy for COVID-19. The frustrating thing is that of course, it can't come soon enough, but it likely is not going to come soon. It probably will be at the earliest early next year, early 2021, or perhaps the end of 2020. In the meantime, I think that other things that have been studied and seem to be effective, using donated plasma from patients who have already gone through the virus, who've been exposed to the virus, and who have mounted antibody responses. Being able to use that as a blood product for someone who becomes ill with a serious case of COVID-19, I think that certainly is also a very a significant development, and something that will probably be available for folks who do ultimately become hospitalized from this virus. But I think that the most important thing for the broader public to understand right now is to be reasonable and sensible with the activities that they choose to engage in out in the public, avoiding large crowds and maintaining that physical distance. And if you are going into places like the supermarket, or you're you live in a very dense neighborhood and walking around on a crowded street, actually wearing that face mask or covering cloth covering over your mouth and nose, and preventing you from transmitting that potentially asymptomatic virus to others, passersby, who might be more vulnerable than you. I think that that, together with the more broader availability of screening tests for this virus, are going to be the most important near-term developments. And after all, we've gotten a lot of practice in the past few months learning how to distance ourselves from each other, give up handshakes and hugs and kisses for a while, perhaps until we have further development of those definitive therapies that are certainly coming down the road.
Great advice. And I'd like to ask each one of you your advice going forward as we come out of this quarantine hibernation here. Dr. Decker, what's your advice for your patients and folks here in this area?
Yeah, I completely agree with Dr. Najarian. I mean, I think a lot of it is just, be responsible and make, good decisions for both yourself and the people around you. And really, it's been a little inspiring, to be honest, to see some of the sense of community that's come from this, and people looking out for each other and trying to put others before themselves, and, the greater good of all kind of above their individual needs. And just, if you're feeling uncomfortable or you're feeling sick or you're afraid of something, just reach out to your healthcare providers, because we're all here to listen and help you through it.
And Dr. Nadelson, you were surprised again at how people were coming out ready to get back to somewhat normal. What's your advice?
Yeah, I would say don't be shy. I think I was telling some of the staff at the office, we were kind of joking around that I think when this quarantine all kind of started, I think people were a little annoyed that they had to stay in their house. And now they had to stay in their house for 2 months. And now I think people are a little annoyed that they can come out. And so I think it's now time that, don't be shy. I mean, if, reach out to your health provider, whether it's your primary care or your GI doctor, whatever it may be, whoever you feel comfortable talking to. We have elective procedures now available and that are available to us. And, we want to make sure that we're being safe and we're doing the right thing by the patients, and by us and by our staff. And I think we'll continue to do that as we move forward.
Dr. Nadimpalli, we'll wrap up with you. And as we head forward, will things return to normal? Do you think things will be kind of change and hopefully for the better going forward?
Yeah, I think unfortunately the normal that we knew is not going to be there for us just yet. I hope that we'll return to a semblance of it at least, but it's going to be stages. I tell my patients this is going to be a bit of a long road, and continue being sensible, continue practicing common sense, and have regard for those of us who are at risk for this virus, because it's not gone. Lifting the stay-at-home order just means that we can start to put some of the pieces of our life back together. So there's going to be a lot of pieces that aren't going to come back for a while. I do like to mention to my patients and check in on their mental health with all of this too. The isolation that comes with this can be quite strong for some, and I urge patients to try to look for some of the silver linings, because I think as we do craft a new normal, maybe we can pick up some of the good things that are coming from this. And personally speaking, I've reconnected with people that I haven't talked to in a long time. The busy day in and day out of normal life kind of let everything to the wayside, and you always think, well, I can talk to them at another time. But this virus is a good excuse to call and say, hey, I haven't talked to you in a while. How are you doing? Are you doing okay? Are your family doing okay? And so I encourage patients to keep doing that. Maybe that's something we'll be better at going forward as we create whatever the future is going to bring. But trying to look for the silver linings, reaching out to people, trying to make sure that you're not isolating yourself to the point where you're suffering from a mental health standpoint, I think is very important to keep in mind.
Great advice. And I think, this forced us all to figure out how to get together like this. And as a public service announcement, and hopefully we can reconnect in a few months like this and talk about things going forward. But I appreciate your time tonight for all of you. I know you have busy lives, and thankfully back at work and doing procedures this week. So thank you very much. And we will post this on YouTube and on the website with all this great information. And of course, visit universitygi.com for anyone out there who has any questions to follow up with a great group of experts. So thank you all again. Have a good night, a great Memorial Day weekend, and be safe.
Thank you.
Thank you.
Thank you. Thank you. Thanks everyone for watching.